Welcome to a podcast brought to you by the American Academy of Orthopaedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Schaefer, and I'm honored to introduce to our Amped podcast audience a new co-host, Dr. Dhinu Jayaseelan. Dhinu, welcome aboard. How are you doing today, my friend?
I'm good, Steve. Thanks.
We are excited here to have you on board. This is going to be your first interview. How are you feeling about that?
I'm excited. I don't like the sound of my own voice, but I think I can bring something positive to the listeners, so I'm excited about it.
I'm excited as well, and I know you're going to do a great job, even if just like me, you don't like the sound of your own voice. Here, that's not going to matter because the content's going to be great. And just as a quick introduction to who you are as a person, can you tell our audience a little bit about yourself?
Sure, yeah. I went to school at GW for my DPT, practiced a couple years in an outpatient setting, got my OCS, then I did my fellowship out at the University of Illinois at Chicago with Carol Courtney. I came back and I've been teaching at the DPT program at GW ever since. I also teach in a couple other residencies and a fellowship. So I'm active with the mentoring and the process of PT. Professionally, most of my work is with the mentoring component, but I also do enjoy a lot of the research that I'm doing. But me as a person, I think is most well defined as being a father of two little boys, Luke and Mark, who are almost 6 and 4. Glad to have kindergarten done and not be a kindergarten teacher anymore, working remotely. And I'm also a husband to my wife, Trish, who is also a physical therapist.
Well, to me, it sounds like you are superbly busy, hopefully all in a very positive way. On this end of things, the last time I had this type of conversation with our audience was back in November of 2018 when we just got things started. I have since left academia, and I am very happy to be living in Canada, which most of our regular listeners should have picked up on along the way. Part of what this means is that in addition to being an AOMPT fellow, I am also now a fellow of the Canadian Academy of Manipulative Physiotherapy, and that's an honor and a privilege as well. So I'm stoked to be in the clinic treating patients and participating in the podcast.
Yeah, and I think having your perspective specifically is great. I mean, as much as it's the AOMPT podcast, we need to really put what we do from an American perspective in a more international scope. And I think having your background is really a good transition and a blend to what physical therapy or physiotherapy is across the globe.
Couldn't agree more. And getting back to you for a moment, what Dhinu has you excited about joining the podcast team?
I think the thing about research that I enjoy is the translation of it. As a clinician myself, I think some of the findings that we'll see in different articles have a lot of good research value, but without an understanding of how to apply those findings, there's a quite a discrete discrepancy between what happens in the lab and what happens in clinic. And I think getting people to talk about their research and highlight how, even if something's done in the lab, how it can apply to the clinic is extremely beneficial to improving patient care and the translation of knowledge, which is always a difficult task.
On this end of things, I can say officially and for the record that the first 2.5 years of the podcast have been amazing. I've really enjoyed the process. I've learned a lot from it, and I think you're going to have that same experience now that you have come aboard onto the podcast team. And if I were to say just one other thing, I'm definitely, and this has been true the whole time, definitely looking forward to hearing some more bloopers and outtakes along the way, because, as finely tuned as some of the, or I should say, hopefully all of the interviews are at the end, we definitely have some mistakes along the way. And in addition just to the hardcore sciencey aspect, it has been fun and it has been funny And maybe someday all of those outtakes and bloopers will be public. But for now, we'll keep those behind the scenes.
Where they probably belong. Yeah,
yeah, that is correct, sir. So on that note, let me just say welcome to the podcast. It is great to have you on board. Hopefully that was a brief but good introduction to you as one of our new hosts. And without any further delay, let's get off to the interview.
Sounds good. Thanks.
Hello, everyone, and welcome to another episode of the AOMPT podcast. My name is Dhinu Jayaseelan, and I'm joined today by Dr. Rick Kranenburg. Dr. Kranenburg received his bachelor's in physiotherapy from Hanze University, a master's degree in manual therapy from the SOMT University of Physiotherapy, and then this year just completed his PhD in medical sciences. Currently, Dr. Kranenburg is a lecturer and postdoctoral researcher in the physiotherapy program at Hanze University, while maintaining clinical practice at Physiotherapy Hoijweg. Today, we will be discussing one of his studies titled Effects of Head and Neck Positions on Blood Flow in the Vertebral, Internal Carotid, and Intracranial Arteries, a systematic review, which was published in October 2009 in JOSPT. Dr. Kranenburg, thank you for joining us today.
Hi, thank you for having me.
And so I wanted to start by kind of getting an idea of how you chose to do this study. So can you start by kind of talking about how you and your colleagues chose to look at this topic?
No problem. The general topic of my PhD thesis was adverse events following cervical manual physical therapy techniques. And during that, I think I started that in 2014, 2015, around that time. So in 2016, the IFOM conference was in Glasgow, which is, in Europe. So I was there, and Roger Carey was actually during one of his talks who said, there's a couple of studies waiting for a systematic review on this topic. Is there anyone interested? Anyone willing to join? And I thought, well, this one fits perfectly in my PhD. I decided to, give it a shot. And, we've seen the result.
And I think it's an important study to do because there's a lot of fear, I guess, about what might happen to the cervical spine if we put it in different positions of stress, or what might happen with joint mobilization manipulation. So can you talk about what you did with your study and what your findings were?
Our general assumption was that if you are changing the position from the head or the neck, and you're stressing an artery, that the diameter of the artery should at least change, right? So if you want any stress on an arterial wall, the diameter of the artery should change. And if the diameter changes, then you should get a different blood flow velocity or blood flow volume, or something should change. We initially thought that there would be like 10, maybe 20 studies published on this topic. We thought it would be a good idea to summarize all the information and see what it does. And if you know what it does and whether it changes blood flow volume or velocity, or whether it doesn't, can help you in your clinical retardation process, whether you or your patient, maybe in some situations, is more or less at risk, something like that.
Briefly describe what your results found and what do you think the conclusions kind of mean for our clinicians?
Yeah, so what we did was we searched in a couple of databases, in PubMed and Embase, CNAL and ICL, which is a chiropractic database. Next to that, we did some hand searches, and we asked some clinicians in the field what kind of information or articles do you think are important? Do you have any information? We got like 1,453 articles. So some articles got excluded because they weren't title and abstract weren't interesting, or they were duplicates. So after that, we had 67 full text articles, and in the end, we ended up including 31 studies. What we did was try to identify what parameters all the studies were using, and describing all the information in those different studies. And that's where it started to get complicated, because most of the studies describe different hemodynamic effects. So some of them were describing peak systolic velocity, for instance, and others were describing the end diastolic velocity, and some were describing a mean flow velocity on time average, but others were describing a mean peak flow velocity, or some were describing blood volume, and on and on and on. So it was pretty hard to get it all together. But that's basically what we did. And we tried to analyze it in different subgroups as well, like the healthy participants without any vascular diseases, but also in the groups with people with, or participants with, all vascular diseases, and patients with anything but vascular diseases. And also between those three subgroups, we couldn't find any relevant differences.
And Rick, you actually bring up an important part, which I think was actually very useful from this study, is that the subjects that you evaluated the data from were not just all healthy subjects, but in fact, actually a number of them had vascular compromise. Can you speak to the limitations with evaluating research for this topic that only includes healthy subjects?
Mm-hmm. Yeah, because it's a very, very delicate subject, of course, and the thing is that we don't know what someone's like on the inside, right? We do know that there's a difference in everyone. If you look at anatomy, some people have a different circle of Willis, or not fully close circle of Willis. Not some people have a vertebral artery which ends somewhere but doesn't attach to the circle of Willis. So are really interesting, but we can't always look inside. We know that people with a Bow-Hunter's syndrome, for instance, which is quite uncommon, but you can't see a bony abnormality from the outside. So for some people without any VBI symptoms, of course, all those tests will be negative. But on some people, they can be negative as well, or positive. But it's still really hard to determine who's what.
I would imagine, to that point, since we do not know the vascular anatomy of individuals, we have to, as clinicians, base our assessment of safety on a patient's subjective and whatever objective measures we can. What clinical exam techniques do you perceive to be the most effective in identifying the people that more commonly have a vascular insufficiency?
I think your anamnesis is actually the most important thing in the whole process. It's the thing the patient will tell you. If they look to the right and they feel dizziness, or if they look to the right, rotate to the right, and you see a nystagmus or some things like that, then they will tell you that they have problems if they rotate to the right, and that it's common for them. or that they feel uncomfortable with that, or things like that. I think that's one of the most important things. Tend to think that those are more reliable actually than your physical assessment.
Which is still actually being commonly taught in entry-level programs and in continuing education programs.
Yeah.
So if our physical exam findings, and there's a number of different reports to show this, if our physical exam findings aren't very sensitive or specific for the condition, why do you think clinicians are still doing them?
Because it gives a sense of safety. However, we should keep in mind for these vascular tests that there might be a false sense of safety here. Because if you look at the study from Nathan Hutting and others in 2013 about the accuracy of vascular tests, then what we know from that study, or what we can learn from that study, is that if you test a patient negative on a VBI test, it does not mean that there's not any vascular compromise. On the other hand, if you test positive, well, you can't really say that it's due to a vascular problem. So, with sensitivity and specificity both not so well, I wouldn't just rely on those tests. I would always combine it with information out of the anamnesis.
And I think that clinical decision making and thought process is only reinforced then by the conclusions of your review, which found that us putting people in positions of brain rotation or extension, as we've historically done to challenge the vascular system, doesn't necessarily do what we think.
No, exactly. And that's really interesting because it challenges the ideas which were originally behind those tests, right? Because if people get symptoms or signs and symptoms, or signs and symptoms are provoked during one of those tests, it doesn't necessarily mean that it's due to a vascular problem, or that the origin of those symptoms is vascular. It can be, but it doesn't have to be. So the whole rationale behind those tests, I think, are challenged with the summary of this literature.
And it also speaks to our clinical practice, I believe, which is, I think, a fear that what we do with our hands, whether it be mobilization techniques or manipulation techniques, or even end range soft tissue techniques, that's somehow associated with the adverse events that have been reported in the cervical spine. And so I want you to speak to, if you can, we know the incidence and prevalence of actual adverse events is really quite low. So why do you think there's a perception that what we do with our hands is correlated to those adverse events, especially since, as you've mentioned in your article, it's quite plausible that CAD is a pre-existing condition, unrelated maybe to positional changes?
Yeah, because we know that CAD can give a neck pain and headache alike other musculoskeletal issues. So it's quite likely that if you have a patient with a CAD which is giving those symptoms, that he's going to look for a physio or manual physical therapist. And if you perform cervical techniques, and especially cervical manipulation, it's quite an intense technique, or people find it a little scary, or and especially if you hear something popping or cracking. Don't know how your patients experience that, but mine sometimes feel that it's really intense or impressive, or at least it's a moment. And especially in the Netherlands, where patients have to sign an informed consent for upper cervical manipulations, it's always a thing, and it especially if you have to sign something, and in the Netherlands you have to sign. There's nothing you have to sign for if you go to a physiotherapist, except for an upper cervical manipulation. So if you perform a technique like that after an informed consent, people will remember it and say, well, then at that moment, he did something like that. And if a neurosurgeon or neurologist or any doctor will ask him, okay, was there a specific trauma to your neck? Then it's very likely that they will remember something like that. And maybe it triggers an already existing CAD. That's possible. But we don't know.
And that's a really great point I think you make as well, is in the effort to be safe and create this informed consent and shared decision making with our patients. In one way, we can almost bias individuals into thinking what we do has maybe more of an impact than it might actually have.
Mm-hmm. Yeah, maybe our consent is working as a nocebo message as well. But on the other hand, you want to give your patients straight information, and but on the other hand, if the risks are really low, we really have to look for an honest way of doing so without compromising negative effects. We don't want to give a placebo message, but we want to be fair and straight as well.
Sure. And to that point, I think it's also important to consider that while the reported incidence prevalence is very low, I believe there's probably a chance that there's an underreporting of adverse events.
Mm-hmm.
So I'm wondering, do you think that it's possible that the incidence prevalence is actually higher than what we think? And should we be more cautious as clinicians when we are doing these techniques, despite systematic reviews such as yours coming out and saying these positional changes don't necessarily impact the vascular system maybe as much as we believe?
I think that whenever an incident or a major adverse event occurs, that we should report it somewhere, either to your own professional association or to your healthcare inspectorate or something like that. And one of the other things we should do is write case reports about it ourselves. We can do it in cooperation with a neurologist or neurosurgeon or whatever doctor treated them in the hospital. But most of the case reports which are published about those cases are published by neurologists or by emergency doctors. So they have a whole different point of view if they're analyzing these patients. They'll write up something like someone went to a physiotherapist or a chiropractor, or they had their neck cracked and they had those and those symptoms. Then they came to us and we saw this and that. We tested that and that, and we did that and that, and the end result is this. But it doesn't give us any information about what the patient was like when it came to the physio. And I think that's the most interesting part at the moment. That's where we can gather new information. What were those patients like initially? Is it indeed the anamnesis or our own inability to detect those patients a priori, right? Is it that we didn't do the anamnesis well enough, that we weren't sharp enough to detect it, or is it really too hard for us to detect it? And I think we also, we should be critical on that, on ourselves, of course. We really have to be critical on ourselves. But on the other hand, if a stroke neurologist or a vascular neurologist already has a hard time identifying those CAD patients with all the means he has, then what do we expect in a private clinic, right, in the first-line clinic?
Yeah, and I would agree, especially as these case reports and case series come out and kind of describe adverse events, especially if we don't have a perspective of the clinician treating, then it creates a bias potentially against our efforts, which maybe is a fault in that way. Similarly, I think because of the possible negative effects, there's this fear and apprehension. Particularly, I notice it with our entry-level students in the States, but it's also within newer clinicians and even seasoned clinicians in some cases, that people are fearful of doing cervical manipulation. They have no problem necessarily doing thoracic manipulation, lumbopelvic manipulation, manipulation at the ankle, or any peripheral joints, but at the neck, there's just an apprehension. People don't want to do it. Knowing that it can be safe if we screen appropriately and we pick our clients appropriately and measure, assess, and check response. What suggestions do you have for students or newer clinicians to just be a little bit more confident that if you choose the technique for the right reasons, that you can do it safely?
I think if you've been doing a very thorough anamnesis and proper assessment for range of motion and everything around it, then and there's no indication for any adverse event, or there are no different signs and symptoms in whatever range, then I think the techniques are relatively safe to use. Because if you look at patients with a bow hunter syndrome, for instance, right, and quite uncommon cause of the TBI issues, and mostly because there's a bony abnormality that may compress the vertebral artery or something like that. All those patients, they give signs and symptoms in a certain range of motion, rotation to the right or to the left or something like that. It's never that those patients will give you just a slight neck pain, which can be provoked by rotation to the left or the right, or the same where you find an extra toned muscle, or maybe a decreased range of motion or things like that. Your clinical retinoation, if it's as solid as you can get it, then I think those techniques are pretty safe.
And I would agree. And I think that works like yours, like your systematic review, helps to create more confidence with making these decisions, which are still going to be based largely on our patient's subjective report. In addition to this project, I was just wondering, do you have similar projects going on that our listeners can potentially be on the lookout for?
We've been doing a quite large survey in the Netherlands with almost 1,000 replies about issues people have between the upper and lower cervical spine, whether there are differences or not. Because in the Netherlands we have a professional standard which applies only for the upper cervical spine. However, in my opinion, it should either apply for the full cervical spine but at least not for only the upper cervical spine, because it's if you look at major adverse events, they happen as often in the mid cervical spine as in the upper cervical spine. So really hard to make a differentiation between those two areas. So we're diving a little deeper into that. About what the therapist perspective is and what they feel as difficult, or why they choose for certain tests, pre-manipulative tests. So yeah, we'll keep working on this topic.
We look forward to those results, as well as additional works you might have in the future. Dr. Kranenburg, thank you again for joining us. For those listeners interested in finding out more or asking Dr. Kranenburg any specific questions related to his work, he can be emailed at h.a.kranenburg@pl.hanze.nl. Dr. Kranenburg, thank you again.
This has been a production of the American Academy of Orthopaedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.